Welcome again, vaqueros. This week we're going to discuss individual treatment or individual therapy. This is out of chapter 7 of our textbook. This is going to be basic theories and approaches to individual or one on one counseling. I don't expect a lot of you to already be familiar with individual counseling theories and individual therapy approaches. This might be the first time you come across it, or you might have heard of it before. Uh, what is your opinion about individual or one on one counseling? Do you think it's done more than other types? Well, if you read the textbook, and from what I can share with you all, one on one private counseling has actually been happening less and less. More likely, when you do any type of counseling in the future, especially addiction counseling, it's going to be group counseling. Now, we're going to talk about group counseling next week, but insurance providers actually allow, because the cost is rather high, to do an hour of one on one private counseling. So that's happening less and less. Again, more likely you might do an individual session with a client maybe once a week, or maybe once every other week, which is really not that often. All right, so a couple of things that we need to absolutely understand, and you probably heard of this before. It's definitely something that's going to come up during quizzes or exams, but it's going to be the 5 stages of change, or in the textbook, it's known as the trans theoretical model. Okay, now the trans theoretical model, uh, it's the same thing. Stage of the change, trans theoretical model. It's beginning on page 167 of the textbook. You have to absolutely become familiar with that, because you should be able to identify what stage of change your client is in. So not all clients come in ready and willing to change, especially when it comes to addiction. These are the 5 stages of change. Number one is pre-contemplation. Pre-contemplation, in the old days, that used to be called denial, and we don't actually use that term anymore in substance use counseling. You might know somebody who is maybe an old school counselor, and they'll still talk about denial. The person's in denial, meaning they don't want to face the problem. Pre-contemplation is the same, pretty much the same definition, except it's just a different term. We absolutely do not use that term denial anymore. The next stage is contemplation. This is the stage when somebody is just thinking about making a possible change. Okay, so if it applies to somebody with a substance use disorder, this is maybe like somebody who has had, like several DWIs, maybe 4 or 5 DWIs, and it happens. And this is at the point where they're thinking, maybe I do have a drinking problem. Maybe I do need to change what's happening. But that slow consideration, that is contemplation, exactly what it sounds like. Stage 3 is preparation. Preparation is when they absolutely want to start working on change and start working on themselves. This is somebody who might already be looking for programs to get into, to different, again, as it applies to addictions, different rehab centers might be coming. This would, so imagine this, preparation would be the ideal client. The ideal client where you actually have somebody come in and they're just willing uh, to want to start changing. And that, I can actually tell you, is quite rare. There's only been a handful of times when I've had clients who came in absolutely prepared and ready to change, and that's really not that often. More likely, you will find clients who are in pre-contemplation. Some of you all might know somebody. Just if you are familiar with people who have substance use disorders, most of the time they don't want to recognize that they have the problem, or they don't want to acknowledge that there's a problem, and they'd rather not do anything about it. The stage number four is action, and that's already when somebody has received treatment, received therapy, they're in therapy, and they are doing with the behaviors that are necessary to change. Okay, so they're doing whatever is recommended for them to change. For example, like this would be, let's say somebody who is trying to abstain from drinking, so they throw out all their alcohol, throw out all their liquor, and they avoid going to bars and things like that. That's the action stage where they're following through with the plan. And then stage five is maintenance. Stage five is really about when somebody's already completed treatment or when somebody has come into some kind of recovery, and at that point they're just doing what they need to do to not fall back. And several weeks from now, we're going to talk about relapse and what that means. But for now, maintenance is the fifth and final stage. All right, so do your best to read over these stages and know them really well. All right, so let's talk about this term intervention. And intervention, some of you might know, is from the TV show, and the action of an intervention is usually to get a person confronted and get them into treatment because they don't want to go, they don't want to recognize that they need to go, kind of like pre-contemplation. It's not just that. An intervention can be any action that causes an individual to try to quit the use of the substance. So not just getting them into a treatment program, but also trying to get them any type of help. But in the terms of an actual intervention, where usually family members confront somebody, does it work? I don't have any experience doing interventions because that's really not allowed with my license. Uh, Usually people would have to come in to an office to get treatment. That's kind of the way it works. But there are people who can provide intervention services, although I choose not to because there's some ethical problems down there at the bottom. You can take a look at that. Uh, you really can't represent yourself in certain ways, and you shouldn't represent yourself as an interventionist. Does it work? Well, we'll talk about that in just a bit. So what we have are the most basic types of individual therapies. Uh, you might have heard of them. Cognitive behavioral therapy, that's out of psychology. Social skills training, and behavioral therapy. These are out of psychology also. These work really well. We can apply these to addiction, substance use disorders. There are other types of therapies out there. Some of them are in the textbook. I'm not going to go over all of them. You should know them. As you become, more advanced and more experienced, you'll get to know about different types of therapy. We're not going to cover them all. Most of the stuff is kind of like graduate level, master's level stuff, but it's good to know them now because this is again something that you can do with only your bachelor's degree. You can practice this type of counseling, and this is one of the points that intrigued me after I graduated with the bachelor's only is that you can actually do this type of counseling and practice this kinds of counseling, whereas other counselors or professions would require that you need to have a master's degree. So therapeutic alliance is the connection, the relationship that you would have with a client. And that's really important. And actually, there's a lot of studies that show that therapeutic alliance is the most important factor in whether a person completes treatment and the treatment outcomes, how well they do after treatment. So what that means is sometimes actually, if you look at the different types of therapies, and they're all important and they all work well, there's no one type of therapy that's more superior to another. But the most important factor is the therapeutic alliance that you have, the relationship you have with your client. So what that means is that even if you do not do behavioral therapy well, if your therapeutic alliance is strong with your client, they can still recover. Their treatment outcomes will be positive. Let's talk about motivation for a few minutes. Let's identify two types of motivation. There's external motivation, or extrinsic, versus internal versus intrinsic. So external motivation comes from the outside. If there's anything, any force that will make a person get into treatment, get into therapy, that's outside of them. It's not necessarily because they want to, but it's for other reasons, external reasons. Versus internal. Internal is because the person is actually self-motivated and actually really wants to get help and wants to get better. So even though sometimes clients say that they are intrinsically motivated, they want to, it's usually because of pressure from family, the legal justice system, a job, or medical reasons to get help. A court order clients, court mandated clients, are mostly externally or extrinsically motivated. So they'll come in with pre-contemplation, they'll be resistant, lack motivation. And how do you help people who don't want the help? Which again, just to prepare you, if you get into this profession of addiction treatment, that's most of the clients. Most clients are not there because they are intrinsically motivated. Most clients are at first extrinsically motivated to go into therapy. So how do you do it? What do you do with a client who does not want help? Well, one approach is, we're going to get into this soon, motivational interviewing. But this slide is a bit out of place, but we'll talk about this. These are some of the concepts, or actually some of the micro skills of motivational interviewing. And all of this is to strengthen the therapeutic alliance. Okay, first thing is that you can't make a person do what they don't want to do. Understand that. Understand that that's not your job as a counselor. It's not to make them do anything. And I really hope that you all don't want to seek this profession and become counselors because you want to tell people what to do, because that's not going to work. If any of you all have personal relationships with anybody who's had substance use problems, you know what that's like when you try to tell somebody what to do. That usually does not work out well at all. So there are a couple of things that you can do. If you know these skills, you can apply these skills. First one is asking open questions. So open questions, some of you might have experience about this from maybe case management or some other course, but open questions are about turning somebody's possible answers into something much more broader. So the next skill would be affirming, which would be something like providing uh, recognition of their strength, kind of like praise, positive encouragement. Number 3 would be reflective listening, which is listening but also being empathetic at the same time, letting the client know that you're listening. And there's a couple of ways that you can do that. We don't have time to get into that in this lecture. Summarizing, which at the end is kind of just replaying back to the person a cohesive message of what was said, deeper understanding, and doing this, informing as well as advising, doing all these will actually strengthen your relationship with your client. Shows that you're trying to understand, shows that you're being empathetic. Okay. And if you have a client who's in pre-contemplation, the very first thing is to try to get that bond, try to get that connection. So now we're going to move into motivational interviewing. So if you take a look at what's been done in the past, there's all different types of therapy. Psychodynamic, which is really old. Reality therapy, sure. Currently, what seems to work really well is motivational interviewing, cognitive behavioral therapy, mindfulness, and pharmacotherapy. Now, that's not to say you can't use one of the other types of therapies. That's fine, but seems to be much. These type of therapies on the right seem to be much more supported by research. So down there at the bottom, that is the actual book on motivational interviewing. It's not required, but I really, really recommend that you get this. If you begin counseling after you graduate, you'd want to read this book. Get this book. It's a great book on how to begin using motivational interviewing techniques. I also recommend that you all attend trainings, workshops, whenever you can. Whenever you hear of motivational interviewing, be a part of that because it is a great skill. I'm going to tell you it does work, and the strength of this of motivational interviewing is to help a person who is in that pre-contemplation stage, a person who does not want or is not motivated uh, for recovery. And this is mostly for addiction counseling, but you can definitely apply this to other types of behaviors. So those of you who are going into other types of counseling, uh, that you want to be an LPC, understand motivational interviewing also because it can help. It began with addiction counseling, but you can apply it to all other types of conditions and mental illness. So there's 5 principles of motivational interviewing. That's to express empathy, roll with resistance, develop discrepancies, support self-efficacy, and avoid argumentation. And I'll provide a video of one of the authors, Dr. William Miller. If you can see that he there's a couple of demonstration videos that he recorded on himself with a client with some clients. I'll go ahead and post that up so you can take a look at everything that he does as far as the motivational interviewing techniques, which is really to avoid judgment but to build a stronger understanding and reflection with clients. Cognitive therapy or cognitive behavioral therapy is using somebody's thoughts, not manipulating necessarily, but using somebody's thoughts to change the way that they behave. So if you believe all behavior is a result of emotions, a result of thoughts, then all you really have to do is change somebody's thought process, and that might change the behavior. So for example, if you would apply this to somebody who is trying to stop drinking, and they would believe that drinking helps them deal with maybe their depression or so on, then what you would do is you would challenge that thought and help somebody by reforming that thought pattern. Thinking that, well, when they get depressed, they're going to go get a drink. Maybe instead of getting a drink, they would work on their thoughts, understand that drinking is only going to uh, exacerbate that depression, make that depression work, and maybe replace it with something. And as a process, that they would eventually learn that depression can be overcome through some other way, and they'll actually not want to drink anymore. It takes a long time, but it's really, really effective. Pharmacotherapy. So there's a lot of kind of recent controversy about pharmacotherapy, which is medication assisted therapy also. And using medications for people with addiction does not go over well with a lot of counselors, a lot of old school people in recovery, because they feel it's a way to substitute one drug for another. So, for example, you can use medications for detoxification, usually for opiates like heroin and opiate prescriptions. And there's a couple of medications that can be used for some substances. So let me go. That is antabuse disulfiram, which can be used as an adverse to keep somebody from drinking. If somebody takes this medication as prescribed, they try to drink, it'll actually cause a nauseating effect and make the person vomit, and through behavioral conditioning, they won't want to drink anymore. And it does work. So really, if somebody's taking this as prescribed, they can't they can't drink. The other one, Suboxone, that's just one brand, but buprenorphine or methadone, that's been used for people with opioid disorders. And it's kind of a blocker. What it does is that it will block the effect of opioids from entering their synapses in the brain, so they really won't get anything off an opioid. It's a safe way to kind of not replace, not substitute, but just to help with the therapy of detox. So again, people are not in favor of, some people, more people are catching on. Some people are not in favor of this because they feel, well, it's just replacing one addiction for another, and it's really not. Don't look at it that way. Look at it as though it's replacing something with medication that's going to help them get better. So let's say like a diabetic who needs to take insulin. Well, do we say the diabetic is addicted to insulin? Do we say that the diabetic uh, is an insulin addict? Well, no, that's not the case. But if they don't take their insulin, they're not going to get any better. Their health is going to suffer. Always, always remember that medication therapy, pharmacotherapy should be given in combination with some type of counseling therapy. So a lot of clients, I've had clients who just want to take a prescription. And again, these are the only substances where prescriptions are available for now. They've been working on cocaine, but that's never really worked out. They don't have anything that's effective for cocaine use. But I've had clients who come in and to see me as a counselor and just ask if there's something that they can take to make the addiction go away, and that's not the case. And towards the end of the chapter, there's a little bit of talk about uh, broad spectrum and harm reduction. In case you're not familiar with harm reduction is actually an approach where the goal is not to completely abstain from the substance use. The goal is actually to reduce the harm that comes with alcohol and drug use. So what this means is, instead of realistically, again, looking at it realistically, instead of thinking, well, let's talk with the client and let's have that person completely stop using all alcohol and drugs. Let's work on with the client instead to reduce and safely decrease how much they use. A lot of people, again, don't see harm reduction as as a goal, but we should look at it because, again, realistically, vaqueros, not all your clients are going to want to stop using alcohol and drugs, but we can support change towards reduction and support change towards positive change. So, for example, harm reduction would be something along the lines of, well, if a person drinks and they drive all the time, one harm reduction approach would be, well, let's help this person drink safely in a way where they will probably be at home or with somebody to prevent them from driving. Because one of the ultimate harms of when somebody drinks and drives is that it causes a public uh, it causes a harm to the public. It's dangerous to the public because it might kill somebody. Another type of harm reduction would be people who inject themselves with needles. Let's give them clean needles so that they won't use the same dirty needles and spread infectious disease. And some people will think that that's kind of like condoning the drug use. It's not condoning the drug use, but it's reducing the risk that comes, the harmful risk that comes with it. Again, it's all about maintaining the therapeutic relationship and understanding that we should meet the client where they are at. So if a client is not seeking uh, abstinence again, in case you're not familiar, abstinence is complete stoppage of all substance use. Not a lot of clients are looking for that, but what are they looking for? And this is something that we miss out on a lot as counselors. We do not listen to our clients, and we do not take what they say into consideration. So if a person wants, instead of drinking an entire case of beer, they want to reduce their drinking to maybe something like a six pack. You know what? You might see that and you might judge that as still being wrong, but we need to, as clinicians, respect what the client's wishes are. And there is a time and a place for educating the client, but at least to start out with, we need to meet the client where they're at and support whatever goals they are. That's our job as a clinician. It takes a long time to understand that our job is just that. It's not to completely cure somebody, which we'll probably not do because there is no cure for addiction. Our job is to provide the service to invoke change in a client. Okay, so we'll talk about that some other time also, but for now, we're done.